This video is for Chapter 12 of your textbook, which is entitled Places of Care. And we start this chapter off by a reminder of some terms that we have discussed in previous videos, that healthcare actually refers to any activity that's intended to improve health. Oftentimes, we treat healthcare as if it's synonymous with medicine, which is the institutionalized system for the scientific diagnosis, treatment, and prevention of illness. But it's just worth noting that healthcare can include, other things beyond that more limited scope. So you can think of all the other ways in which you can seek to improve your health. Activities related to diet, exercise, mental and social well-being. All of those activities would be, of course, considered healthcare under this definition, even if they aren't necessarily what we think of when we discuss healthcare. All healthcare takes place in some spatial context or location. These activities, they have to take place somewhere. And where it takes place is oftentimes decided by social policy, which your book notes, they'll discuss in extended fashion in the subsequent chapter, chapter 13. But there are debates concerning which is the better setting, institutional settings or community settings. And this debate is further complicated by the fact that there is not necessarily a clear-cut definition in regards to community, which of course, thus complicates, what do we mean when we are discussing community care? And for many people, despite saying that healthcare isn't just limited to medicine and that healthcare can take place in a variety of settings and contexts, for many people, because they think of healthcare as being medicine, that means that oftentimes they assume that hospitals are the normative place for the provision of healthcare. And so this chapter begins by really trying to discuss hospitals as a organization. And they want to understand hospitals better by turning to sociologists who have theorized about organizations, bureaucracies, and institutions. And so the first sociologist, theorist that this chapter introduces is Max Faber. And they introduce Faber by discussing how he saw all human action as being purposeful. And he was interested in understanding the meanings that people attach to what they do. And he proposed that there were three forms of action, that there was action, effective emotional action, traditional action, and rational action. And so with the effective emotional action, the kind of motivation there is, it has to do with a person's individual emotional state at that given time. That's what's motivating their action. While traditional action, is activity that we engage in because we always have. It's activity based on what we as individuals are used to doing, what our society, our culture, presents to us as being the norm or the tradition. And then finally, there is rational action. And as your book describes it, this is purposeful action where there is an intended outcome to our actions. And so Weber thought that as society becomes more complex, that rational action was going to become more predominant and prevalent, because a more complex society would need to find rational ways in which to organize itself. And he saw that these modern societies would be organized around bureaucracies. And so, it's important to note that when we discuss Weber's conception of bureaucracy, even he noted that this is an ideal type. So he was saying, in a perfect world, this is what a bureaucracy should look like. This is how it should run. This is how it should be organized, and this is what it should be based upon. He was very aware that if you think about the bureaucracies that actually exist in society, they often fall short of these ideals in a variety of ways. But in terms of the ideal type, this is what we expect from a bureaucracy. First of all, a bureaucracy is just an expert system of administration, and it's based on several characteristics. It's based on detailed documentation. It's based on formal rules and regulations. It's the idea that the decisions made by the bureaucracy should be made through the application of specific procedures, and that those procedures exist in order to eliminate subjective judgments, that bureaucracies have legitimacy because people who work for the bureaucracy are supposed to separate their individual personality from the task that's being done. So the people who work in a bureaucracy are supposed to be motivated by that rational action as opposed to emotional action. Authority is the characteristic of the post and not the post holder, right? So, it's the idea that if we say, we respect, doctors, the head of medical fields in a hospital, it's the idea that all the heads have that authority, that it's not just, the ones you like or the ones you prefer, or the ones who look a certain way or have, a certain, demographic characteristic, right? The authority is supposed to come from the position itself. And people are supposed to have those positions because they met the formal qualifications and they have the correct credentials. So that was that ideal type. But if you've ever, and we've all, of course, universities are bureaucracies, government, local and state governments are bureaucracies. Like think about the DMV, a large hospital is a bureaucracy. So we all have experience with bureaucracies. So that oftentimes they fall short of that ideal type. Another sociologist, Peter Blau, was especially interested in how sometimes the workers who are oftentimes not involved in, the construction of those procedures that are supposed to be efficient and ideal because they eliminate subjective judgments. But when Peter Blau, researched organizations, he was interested in the ways in which that humans, because we aren't robots, we often subvert the expectations associated with our organizations and our positions. And for him in particular, he was interested in how by engaging in these informal working practices, these working practices that aren't sanctioned by the organization itself, and these practices are called contra. Blau discovered that sometimes these practices actually improve the overall working of the organization. So just saying, sometimes, when you follow all the rules and procedures to a T, and getting bogged down in red tape and paperwork, sometimes that isn't really efficient. And sometimes it is the workers who discover those inefficiencies and they come up with informal working practices that make. I had dogs barking there, so I had to pause. So hopefully I'm picking up at the right spot. But it's this idea that sometimes the workers, when they develop these contra, they wind up improving the overall working of the organization. And if you've ever had experience where you've worked a job and maybe you and your coworkers, come up with a way of doing something or handling a problem or addressing a situation that isn't necessarily by the book, but works just as well and perhaps even better, then you have a better understanding of contra than what you might expect. The next sociologist that your book talks about in regards to organizations was Foucault. And specifically, they start off by introducing him by focusing on how his uh, research, his theories were really about the importance of physical layout. And so the authors remind us that every hospital has a specifically designed building with certain features that aid in its function. However, Foucault argued that the design of architectural space is not always neutral or utilitarian, meaning, the space doesn't just reflect, the best way or the most efficient way to, for the setting to be constructed so that it can address its needs. Instead, Foucault suggested that architectural space often reflects the power imbalances that exist within the setting. It reflects authority and ways of controlling people. And particularly that ways of controlling people, the concept of surveillance was key to Foucault's idea. He discusses it in terms of, how architectural spaces can be set up so that people who have authority over other people within that space, they can directly observe, people at all times, or at least make them think that they are possibly being observed at all times. And then, of course, the other way that the book discusses surveillance is the keeping and the maintenance of written records, right? So it's not even just that you're being observed in that moment, but then it's recorded and it's saved, and those records follow you over time. And so he was particularly critical of institutionalization. And he talked about how asylums, especially a lot of old school asylums, had what he described as this panopticon design. And I give you like an example of what that looks like in like the real world, in that upper level picture, right? It's that idea that, there is like this central area that is where the authority resides. And then surrounding it are these kind of open cells, where the people in authority can kind of look out and directly observe people at all times. And, you might recognize this type of architectural setup if you've ever watched like a prison show or visited a prison. This is very similar to how a lot of prisons are set up, where you can have the guards in the tower and they are looking out and over like the individual jail cells. And so, the fact that a lot of, asylums had that type of architectural construction, made Foucault very critical. And he later was equally critical even when asylums embraced moral treatment. He really just did not trust the goals and intentions of institutionalization. And he saw the goal of these institutions as being the creation of docile bodies more so than healthcare. So more about having perfect patients that obey and follow the rules, and less concerned about helping people get better, providing them the resources they need to be better. He certainly wasn't the only sociologist that was critical of institutionalization. Your book introduces two others, Skoll, who specifically in his critiques on institutionalization in asylums, he concentrated on the needs of capitalism and the effects of urbanization. Skoll saw asylums as being a dumping ground for people who, for a variety of reasons, just had no real purpose and were not productive in a capitalist, capitalist-driven urban area. He also was critical about the medical profession. In particular, he highlighted the opportunistic nature of the medical profession. And keep in mind, this was specifically in regards to asylums and mental health. So, he said, by defining mental illness with that medical model definition, that medical professionals, they kind of created the perception that they alone were capable of diagnosing and treating people who had mental illness. And so over time, they became the socially approved route that patients and patients' families would sought out. And Skoll was just very kind of skeptical of this approach because he saw it as them kind of creating consistent clientele for their services. And then the final theorist, who weighed in with critiques of institutionalization is a name that you might recognize from past chapters, and that's Erving Goffman, because we've already discussed his contributions to the social construction approach to mental illness through his concept of like stigma and his discussion of passing versus, master status. This chapter introduces us to his concept of total institutions. And total institutions, you want to think about it like this. For most of us, if we never experience a total institution, our lives are shaped and structured and influenced by a multitude of social institutions, because if you're not in a total institution, you have day to day, week by week, month by month, year by year, you're exposed to all of the social institutions that make up a given society, family, education, media, government, science, religion, maybe, your peers. All of those are social institutions. And social institutions, one of their primary roles is they socialize us, right? They give us messages about the society that we live in. The institutions teach us our social roles. They impart our society's values and beliefs. And, the idea is that you might get, different messages from different institutions, which means that you have to display some agency, and you have to figure some things out for yourself. You have to make decisions. You have to choose, to support this belief over this other, to, have this value maybe as opposed to that value. But that's what we do when we're not part of a total institution. Total institutions are institutions that once you become a part of that institution is now fully in control of really all aspects of your life. And you don't have these other institutions, weighing in and influencing you. Instead, it's just this institution and its beliefs, its values, its norms. So examples of total institutions, obviously mental asylums, because that's what Goffman was focused on when he created the concept. However, this concept of total institution has also been applied to things like prisons, the military. That's oftentimes seen as being a total institution as well. And I'm sure, you could probably think of a few others, but it's worth noting that it's not like total institutions are super numerous, which is why for a lot of us, if you're never a prisoner, if you're never institutionalized in a mental hospital or some other type of long-term care facility, if you don't join the military, for a lot of us, we will go through life never experiencing a total institution. And so therefore, what he then describes, this concept of a moral career, which is this idea that, when you enter a total institution, your life is changed. That whatever identity that you had before, that identity now no longer matters. And that especially for mental health patients of the asylum, it's about a process that leads to you basically losing your original identity and having another identity foisted upon you, that you then are kind of placed in the position of how are you going to respond to that. And so, he talks about the moral career, that there are stages. There is the mortification of self, which is basically, the total institution finds ways to remove the person's identity referring to them by last name, or if it's a prison, maybe just referring to them by their prison number. If it's the military, requiring the haircut and specific uniforms. But, basically your old self is destroyed. And then the next phase is the reorganization of self, which is the institution's way of replacing the identity that they took away. So they now are giving you the identity that they want you to have in that space. Now, how do people respond? And I think what Goffman is doing here is saying, not everyone just accepts this, and not everyone just, accepts this, happily. So he discusses, patient responses, colonization, where you adapt, but it's unenthusiastically; conversion, you accept. And you accept your new identity pretty willingly, and he refers to this as being institutionalized. Withdrawal, where you just kind of try to minimize contact with people within the institution as much as possible, so you aren't kind of having to embrace this new self. Intransigence, this is someone fighting back, someone pushing back. This is resistance to being converted. And then playing it cool. And so this adaptation, as Goffman says, this is the one where you're trying to maximize the chances of surviving the institution with as much of your original identity intact. And so it involves minimizing your visibility and staying out of trouble, but not to the point where you actually are adopting the new identity, like people who are, experiencing the responding in the colonization or the conversion way. But then it's not a full-scale withdrawal either. So that was kind of Goffman. So, certainly after having the sociologists weigh in, it seems pretty clear that there are problems that can arise from institutional care. And, on 213, they list some: dependency of clients on the institution, the iatrogenic effect of care, difficulties in returning people to life outside of the institution. So certainly there are problems with institutionalization, but the authors do push back against the idea that these problems mean that community care is inherently better and preferable. And part of the problem is just because, especially early on, community care, there was no consistency in what that looked like. There was no follow-up. There was no follow-through. They talked about how someone described it as the sociological equivalent of Siberia. So you just kind of push people out the institution and say, oh, the community will take care of them. Just making that assumption without, really knowing what resources are available or what happens to the person. And of course, the other kind of reason why the authors push back against this idea that community care is inherently better and preferable is because they later point out that, in a lot of ways, settings that we would consider to be community care, in many ways, those settings can also resemble institutional care. When you think about the number of healthcare professionals, that do home visits, or, that go to like senior citizen homes and senior citizen, day facilities, and, provide these services, and it kind of just blurs the line about, okay, well, is this that different from institutional care? And if the answer is not really, then once again, it just raises that whole, it just pushes back against that whole assumption that community care is definitively the better way to proceed. But beyond the kind of problems of finance and service provision, one issue that comes up when talking about community care is just even trying to understand what that term community even means. And so there's this whole discussion in your textbook about how people perceive communities, that oftentimes the way that people perceive them, these urban villages, dense social networks, voluntary participation in civic society. In a lot of ways, this no longer aligns with how many people, with how many people actually live that way and behave that way. We live in a time where, because of globalization, because of urbanization, modernization, less work-life balance, just more individualization, a lot of those old kind of perceptions of community, you do not see them in many places. But if you look at how, researchers and people who write about community, if you look at how they use it, there isn't any clarity there either, because they use it in a variety of ways. They use it to refer to geographical expression, like, oh, that community on the south side of town. They use it to refer to a local social system with interconnections between people and institutions, like, oh yes, we're all a community here. We all attend this church. We all go have brunch at this restaurant. Everyone who has kids, they take their kids to this park and they're on these ball teams. So, we're a great community. That's a different way of defining community. And then, of course, you can define community in such a way that there's no logical connection to places or local social systems. You say things like the African American community. You say things like the evangelical community. In that sense, when you're kind of basing it on this really kind of broad demographic, trait that kind of goes beyond local or geographic boundaries, that's obviously a very different definition of community than the ones that preceded it. But, regardless of how you define it, the key thing about community care is the idea that it is outside of these institutions that largely are run like bureaucracies. And at least in the United States, we definitely had a period between the 60s and the 80s where we kind of forced community care upon people. And this was discussed in the mental health chapter, but deinstitutionalization was the release of people from hospitals into local communities. And with the focus being not people that had acute illnesses, but people that had disabilities and mental health disorders. And so this was sparked by JFK in the Community Mental Health Centers Construction Act of 1963. And then it was exacerbated during the Reagan years as the federal government cut funds to states to have kind of, these state mental hospitals, these state mental asylums. So with less funds and these institutions becoming privatized as opposed to public, there was this shift from inpatient care to outpatient care, from institutions, which, to use Goffman's term, certainly a lot of them were run like total institutions where patients had very little control. Instead, now it was outpatient centers where you were kind of dependent on patients seeking out treatment, following their treatment plans outside of the watchful eyes of, doctors and nurses and healthcare staff. And this is certainly one problem that people who study mental illness, one problem that they point out with deinstitutionalization, which is without the resources to check up on what's going on in the community. Are people following their regimens? We know that a lot of people who have serious mental illness oftentimes do not receive regular treatment. They do not come into, they aren't receiving their outpatient care from these community centers. And that's because the other thing about the community care is that, in the formal context, we are aware of who provides the care, that they have been trained, that they have their professional obligations and responsibilities, but there isn't that type of clear-cut answer of, who is providing the care and how well are they providing it, outside of the institution in the communities. So in the informal context, people are reliant on informal care. And the two components that kind of comprise informal care is service. It's the idea that you have to do things for people who are relying on your care. And that usually you're doing it because you have affection for them, you care about them. And for most people, that informal care is provided and received on the basis of kinship and family ties. And so reciprocity is thus another component of informal care when it's being provided by kin. You expect your spouse, your, adult children, if you're young, your parents, you expect these people to take care of you because that is an expectation associated with being kin, with being family. And the idea is, of course, is at some point, if they were to need that type of care, the expectation of reciprocity means that you would then provide it for them. Now, why do people oftentimes rely on family to provide this care, even if they have the resources to maybe hire someone? It has a lot to do with how, when you are reliant upon informal care, this is oftentimes a violation of the expectations of the civilized body, which we've talked about in this class, right? It violates the idea that that you have this right to privacy in regards to your body and bodily functions. And, oftentimes if you're receiving this type of care, you maybe have lost control over your body and your bodily functions, which, it can be embarrassing or upsetting. And so it is a level of vulnerability that a lot of people, only feel comfortable demonstrating, with family and close family at that. Your book does note that a lot of this informal care is gendered, with women being caretakers. And this is true whether it's the informal care, or it's even true if you're talking about the formal context. If you're talking about, nurses and CNAs and some of those types of, helping professions, a lot of that is done by women. And if it's part of the formal context, certainly like CNAs and those types of positions, people that work in nursing homes, as nursing home assistants and what have you, these aren't the highest paid jobs. They're not, they provide a valuable service in society, but they're oftentimes devalued in terms of in financial incentive and benefits. And then if you think about it in regards to the informal context, it's usually the women in the families, mothers and daughters and wives, that are providing this care. And once again, there is still this same kind of level of devaluing and lack of gratitude, and the expectation that the women in these families, because they are women, because they have that gendered expectation that they're going to be loving and nurturing, that they're expected to provide this care much more so than the men in their family. Now, your book does note that there is a class element here. Obviously, if people have the resources, they can outsource some of these care duties to paid people who are paid to provide this type of work. And they say that this is particularly the case for like upper middle class men, that if this care falls upon them and they have the resources, they just outsource it to someone else, usually a woman, who it's her job to provide this type of care. So working poor men are more likely to provide this type of care than middle class men are. Largely because they don't have the financial ability to outsource it to someone else. And so your book notes that, when it comes to caring for, people, whether it's people in your family or, whether it is, the job that you're getting paid to do, it can range from fulfilling to draining. But especially in the informal context, for many carers, they do have, a lot of issues regarding, restriction of activity. Their activities are restricted because of the care demands of taking care of someone else. Time, if they are trying to, combine their care duties with other household duties or, paid labor, obviously they run into real time constraints. And then money, the fact that a lot of this is not being subsidized it's coming out of the family budget, being having to, whether that's making changes in how your home is laid out, buying specific supplies, making sure that you have resources on hand. If it takes away from the carer's ability to hold down a full-time, paid job, so certainly, this burden of caring definitely has some real kind of logical negative consequences. And so where is this informal care taking place? A lot of it is taking place in the home. And I think your book, acknowledges that home can have multiple meanings to people, right? So, if I was to ask you, what does it mean? What does your home mean to you? You all probably would have different answers to that. And your book points out that, home can have meanings related to memory, to family, to being a safe haven. It can be, meanings that are gendered, meanings that are related to your identity, who you are. And so this does mean that when care is located in the home, it can present unique challenges and potential problems in terms of, how you have to organize and set up and change the space, the kind of disruptions in people's day-to-day activities. If you have like medical, practitioners or, home social workers coming in and out for visits, if you have to kind of reorganize, kind of people's daily routines and where they take place in the home around the person who needs the caregiving. All of these are things that people don't necessarily think of, when they initially build and set up their homes. But if they have to start providing uh, uh, informal care to someone in their family in the home setting, these become things that they then have to address. And the number of people that are facing that, it has grown over the last, over the last couple of decades, and it's projected to continue to grow. And that's because we have an aging baby boom population. They're more likely to be plagued with chronic illnesses as opposed to dying rather quickly of an acute illness. And we still, for the most part, with healthcare costs, and still kind of a focus on, deinstitutionalization, um, you know, a, a lot of that care is going to happen in, as they get older, as they start to need care. A lot of that care is going to be taking place in the informal context, as opposed to the formal institutionalized context. So, if this isn't something that, you have faced or confronted in your own families, it's highly likely that you will at some point. And that is it for this chapter. I'll have a separate video for the chapter 13 on health policy.